Thank you for having this interview with me. I would like to say that robotic technology is not a robotic technology. It's a kind of telementoring. A surgeon makes some moves, and this equipment, which we call robot, carries all his abilities into the cavity, into the human body. So by this way you can perform the surgery. This is the replication of the all hand movements of the surgeon in the virtual reality. It's different than videothoracoscopic surgery. In videothoracoscopic surgery, the surgeon is at the table and perform his tasks with what the uniform standardized equipments in a standard way. But in robotic surgery, surgeon is not at the table, surgeon is at the console. Even he can be outside the hospital, or even he can stay at home. And in the next years it may happen so. But the quality of the movements are being scaled, filtered, and transferred into the thoracic cavity. That is the current status of robotic surgery. Yet, for today, we cannot demonstrate the benefits of robotic surgery sharply. But in the near future, when the big data comes, when we collect more data, as you know, robotic surgery started in China and coming with high numbers, and we are looking forward to hear the results of Chinese surgeons on robotic surgery. Then I think we can produce the results concretely, and maybe we may have a chance to demonstrate the benefits of robotic surgery by this way. It's more expensive than the conventional videothoracoscopic surgery. But you know, this changes from country to country. If you are performing these operations in the United States, it may even be cheaper than open surgery, because the duration of stay is extremely important in American hospitals. And if you are performing this operation in Turkey in a private hospital, it can be even economic compared to the videothoracoscopy if patient stays shorter, because in private hospitals in Turkey, single day cost of a wardroom is very much expensive, like the ones in the United States. But in China, in state hospital, I see the results that people can stay like 14 days, 20 days after a robotic operation, because it's cheap, because it's state hospital, it's reimbursed totally. So the country you are in defines if it's cheaper or it's expensive. For China, it's very expensive, I guess. Yeah. But the good thing is, in a few years, there will be 5 other companies as the surgical robots in the market, which certainly will decrease the cost of the equipment, machine, and the utility costs like maintenance, annual care of the robot. The costs will come down, and it will be more generalized. This is the major challenge against the robotic surgery. The second challenge is education. As there are few thoracic surgeons performing these operations, education is not disseminated as it is in VATS. It's a more complicated procedure. It needs the understanding of the machine, understanding of the robot, and use it like you use your car. You have to use it like you are using your car. You are not using only 2 hands, but also your legs for visualizing, for camera, because you are also guiding the camera in robotic surgery. There is not someone else holding the camera for you, and which is better because you can show wherever you want easily. But you need your legs to move the camera and to cauterize during the surgery. As I told you, the second challenge is the education. In the next years, as I have replied in my previous question, I am expecting new robots in the market which decrease the cost, and dissemination will be very rapid afterwards. and this will increase the utility of robotic surgery. And what I'm expecting to see is with new availabilities in the market, there will be some other developments in the technical capabilities of the robotic surgery. We saw several changes, several adoptions in robotic surgery, like robotic stapler, which was a dream several years ago. You can now use the robotic arms for stapling. You do not need anybody to staple it from outside. And also there is Fireflyer, which can demonstrate you the healthy tissue and then the tumor tissue. And also there are other modules that are going to be implemented in the robotic surgery. One of them may be augmented reality. You know, augmented reality is being prepared for the robotic surgery. During dissection, you are going to be warned about what is next, what is behind this tissue. It will warn you, telling that there's pulmonary artery, be careful. So the machines, the robots, actually they are not robots, as I have told you, they are machines. These machines will be more helpful in the next coming years. In the future, yes. In the near future, I don't know. I am 100% sure that robotic technology will replace VATS or laparoscopic surgery. But I don't know how close is this future. This is mostly depending on the economical conditions of the next generation robots. Turkey is not an easy country. It's somehow similar to China. It's a close community, and people sometimes maybe harsh and managed difficult, and expectation is very high among the patients. I mean, people want to have the highest quality of service, you know, for free, which is impossible. You know, state hospitals provide all the health care for all Turkish citizens, even for immigrants. Turkish government provides a good health care, but the expectation is still high among the people. They want the best surgeons to operate on them. They refuse residence operations on the current practice, and they do not accept morbidity and mortality, and that may be challenging if you face a serious complications or an unexpected mortality, maybe even dangerous for the health of the surgeon. In terms of surgery, we do not have too much topics to develop the quality of the surgery. Well, we have already defined quality predictors in lung cancer surgery, which are well known and obvious, like the number of lymph node dissections and the use of certain investigations in the preoperative period, and then the standard applications in the postoperative use. What we did not have is the small resections. There are several ongoing research on small resections on patients who are compromised, who have lesser pulmonary functions to overcome a big major lung cancer surgery. So these patients have small resections, which we call segmentectomy, and all around the world several studies are being done to compare standard lung cancer operations versus smaller operations versus SPRT, which is a radiological method which is being developed, and the data that we are not certain about their data, if it is comparable with the smaller resections or not, we will see it in the next years. I am involved in such smaller resection studies. In the previous years, I was very much involved in the lymph node issue, I certainly believe that lymph node dissection, the amount of lymph node dissected and the range of lymph node dissection increases the quality of surgery and decreases the recurrence rates. And but this data we could not produce this expectation by the data or by the researches that's being done all around the world. So now the topic changed to the bigness of the resection.